Good afternoon, doctors. Hope you all are doing good. It gives me immense pleasure to welcome you all to this panel discussion on the topic why an early pregnancy, USG normal, land in, bleeding, PV bleeding, and subsequent loss of pregnancy. What went wrong? Treatment or wrong ultrasound report? Indeed, some light needs to be put on this topic. Now, welcoming our panelists in this discussion. Firstly, we have Dr. A.B. Vani sir, who is the Director and CEO of BillMed. He himself trained 25,000 doctors globally. Secondly, we have Dr. Jyoti Malik, DNB, Obstetrics Gynae, FICOG, IVF Gold Medalist and also President Awardee. Thirdly, we have Dr. Harjinder Kaur, MBBS and sonologist. She is a member of FOXY in Rewari and also senior most active gynae practicing in Gurgaon. Not only this, but she is also 48 years experience in gynae. Last but not at the least, we have Dr. Sunita Gogate, MBBS, DGO, MRCOG, FMAS, practicing since 20 years as a gynae, and she is also a specialist in laparoscopy. She is joining us from Mumbai. Now, I request Dr. Vani sir to start the discussion. Thank you.
Yeah, good afternoon and greetings from BillMed Ultrasound Training Institute. Today we are taking a short, discussion, a panel discussion on a topic which is very important. Usually we are getting reports, and these reports can be of two types. One is normal and one is abnormal. Okay, you got a normal report. If you got an abnormal report, you will get on your toes, you will give a supportive therapy, this way, that way, you give the appropriate treatment. But the point is, if you are getting a normal report, I mean the normal early pregnancy report, you are getting happy. You are getting happy that everything is normal. But that patient is coming to you after 4 or 5 days with PV bleeding. And when you are taking a rescan, you are getting a report of RPOC, retained products or blood clots. Then the question starts arising in your mind. What went wrong? So that will be our discussion. What went wrong? There are two possibilities only. I am repeating, only two possibilities can be there. Either you have not treated well that patient, or that so-called normal ultrasound report was not normal. So let us see what went wrong. Was that early pregnancy normal ultrasound actually a normal ultrasound report, or everything is your fault, I mean the treatment part? So with me are having Dr. Jyoti Malik, Dr. Harjinder and Dr. Sunita Gogate. They are senior most gynecologists. They are doing themselves a basic scan, but today we will discuss with them as a gynecologist that a report is coming to them with a format of, let's see the format of the report first. Can I see the format of the first report? And let me discuss that with Dr. Jyoti Malik. So can I have the first report? Now, Dr. Jyoti Malik.
Yes, sir.
This is your report which you are, sending me. And over here, no, this is not that report. Send me the Dr. Jyoti Malik's report. Next one, not this one, next one. Is that? Yeah. Now over here is an early pregnancy report. Now you can see that this is an early pregnancy report of 7 weeks and 1 day. The LMP is mentioned, the ADD is mentioned, the uterus is mentioned over there. And now the most important part is the intrauterine gestational sac is measuring this much and corresponding to this much. And CRL is corresponding to 7 weeks and 2 days. Fetal heart rate is 151. I am reading the report. So this report is absolutely normal with an impression of single live intrauterine gestation corresponding to 7 weeks and 2 days. Now this patient is coming to you and has come to you after how many days?
So 3 days.
After 3 days.
She came back again. Actually, she came with this report for the first time. I started her on normal treatment, which we are offering to all our patients. And then I just asked her whether you are having any previous abnormalities or any history of spotting in the same pregnancy or something there. So she was like, "No, I'm absolutely fine."
So the one line is that you have got a normal ultrasound report, and after 3 days the patient is coming with PV bleeding.
Yes.
And now you are not justifying yourself what
And
went wrong over here.
I was not able to find out what happened to her. So
Now see, there is one thing which I can see over here. Everything looks normal. Point number one, what is missing over here is the yolk sac. Where is the yolk sac? Where is the yolk sac over here?
Actually, sir, actually I didn't inquired about the yolk sac.
Because you may not be aware of the importance of the yolk sac in early pregnancy. Now over here in this report, I am not seeing the yolk sac. Now let us see how important this yolk sac is. And maybe in this case, it was an abnormal yolk sac which was not scanned by the doctor, which has landed into that abnormal bleeding and subsequent the loss of the pregnancy. Now let us see the importance of the yolk sac in early pregnancy. Can I have a PPT? So in each and every early pregnancy, we should see a yolk sac. And if you are not, you are a gynecologist. It is you who have to, take a final decision. It is you who have to take the appropriate measures. And if you are not knowing that the yolk sac is important, you will not ask for the yolk sac.
Yes.
Now, see over here. Next, go to the yolk sac. Now, this is the complete PPT. This is rather a full-fledged course over there. Now, we will go to the yolk sac only. Hurry up, go to the yolk sac. Now, yolk sac is very, very important. Yolk sac is a God's given tiffin. God's given tiffin. Keep on scrolling. Till the placenta takes its function. Yolk sac should be regular. By regular, I means the shape has to be round and round only. Now, if you don't have a round, you have a square shaped, star shaped, anything, but not a round, that is abnormal. Point number one. Point number second, you have to see to the internal contents of the yolk sac, and the yolk sac should be jet black. I am repeating, the jet black only. Third is the measurement. You have to see for the yolk sac measurement. Yolk sac should not be very big and it should not be very small. And lastly, you have to see for the walls of the yolk sac. Yolk sac should not be calcified. Now I will show you. Now see, now you are knowing that yolk sac is important. Next time when the report will come, if there is missing yolk sac, you will ask for the yolk sac. But unless and until you don't know about the importance, you will not ask for the yolk sac. Now see this yolk sac. Next. Now this yolk sac. Next. Now this yolk sac is a God's given tiffin till the placenta takes on its function. This yolk sac, as told by me earlier also, should be jet black. Next. Jet black should be jet black, and the measurement part should not be less than 2 and it should not be more than 5. So make a note, it should not be less than 2, it should not be more than 6. Now see it over here, the yolk sac, the internal contents of the yolk sac should be jet black like this. It should be jet black over here. It should be jet black. Now see to the yolk sac, which is round. I told you it has to be round and round only. Now see over here. Next. Now over here. Next. Hold on. Now I told you it should not be too large, it should not be too small. it should not be more than 6 millimeters. It should not be less than 2 millimeters because now see over here, because the yolk sac assessment to spontaneous abortion prediction, if the yolk sac is more than 6 or less than 2, is about a 95%. Maybe in your report it was too small because it is not mentioned over there. Now next time if the same report will come to you, you will rescan that patient, not rescan, you will send back to that patient, to that doctor, whosoever is doing the ultrasound, and will ask, now if your yolk sac, next, if your yolk sac in that patient is irregular shaped, mainly if it is wrinkled with indented walls, that means the irregular shape is there, and if there are degenerative changes, if there are some internal contents over there, now you have to see what is normal and what is abnormal. Now let us see a normal yolk sac. Normal yolk sac, the size has to be in between. On an average it is 5 to 6 millimeters, and if it is too small or too large, or number second, the shape, it has to be round and round only, and I told you it has to be the center has to be jet black and only. Now you know that yolk sac is important. There are chances that report was actually abnormal because the yolk sac was not defined over there. Okay, so now you know the things. When you know the things, you will ask for in next report, because the patient will come to you, madam, what happened wrong? He or she will not, she will not go to that radiologist that what went wrong. She will come to you because you are the consultant doctor, you are the judge over there, you have to take the decision.
So
okay,
in future I will always check for the yolk sac whether it is mentioned and how properly the report is written, whether the contents or everything is nicely written there or not. And if I ever found anything missing, I'll again send patient back to the concerned radiologist so that I can have a proper full report.
Okay, now see, the most important point is when you will ask for these things, then only that doctor will open up the book. Then he will see what wire has to done. Otherwise, he is starting dictating you. This is normal, madam, and this is abnormal. Now you will, now if you are well versed, you will not listen to him. You will tell him, why is this thing, why is that thing? Then he will come with his books, which are on shelves, and he will go through the books, and then only the patient will get a good ultrasound report plus the treatment. Okay?
Yes, sir.
Now, there is one more report from Dr. Harjinder Kaur. Can I see the report, please? So, what was your case, Dr. Harjinder Kaur? What was your case?
Sir, there has been a patient with me with early pregnancy, and as we are doing in the routine checkups, I advise her to get an ultrasound. And she brought the ultrasound. As we are gynecologists, we mostly see that this is intrauterine, it becomes happy, and cardiac activity is present. And the conclusion was ongoing pregnancy. I was happy, so I assured the patient also and the attendant also. But after 7 days, she comes with a bleeding, and again I advised her to repeat the ultrasound. Then it was shocking. There was no cardiac activity present. So it was very difficult.
Now see, madam, again this is the same thing. Unless and until I will not see the report, I cannot say where is the fault. Whether it was your treatment part or it was the radiologist or the sonologist, whosoever has done the report. Can I see the report? Show me the report, please. Now, in your report, I will see first, you know what to see. You have to see for the cardiac activity, you have to see for any detachment. Now you have to see for the yolk sac. Was yolk sac mentioned over there or not? I don't know because I have not seen the report. You guys please show me the report. Was yolk sac mentioned over there? Now let us see to the report. So please show me the report of Dr. Harjinder Kaur's patient.
Sir, mostly we are depending on their report. They are giving normal report. We are separated as such. We don't go in the details. Present or not?
This is the report?
Yes.
Now see first, what is written over here? That there is a single embryo with a CRL of this, which is corresponding to 7 weeks and 1 day cardiac activity is present. But there is one small thing which is mentioned over here, that a coily subchorionic bleeding is measuring this much, which is around the gestational sac. Now pay attention to the word written over. First of all, this is coily. This is coily. Okay, even if it is not a coily, what is wrong over here? That doctor is writing that there is a small detachment over there, and you took it for granted because not of this smallness. Try to understand.
Yes.
Because not of this smallness, but it is written around the gestational sac. It is not written where it is.
Yes.
Point number one. Point number second, again the yolk sac is missing over here. There is no no yolk sac mentioned over here. Maybe. So, point number one, maybe that yolk sac which we have discussed right now was abnormal. Point number second, maybe this small hematoma, this small detachment was detaching the future placenta, that is the chorionic frontosum. So more important is that this subchorionic bleeding is at the level of the chorionic frontosum or detaching the chorionic leaf only. Now you will say that how can I see or anybody see a placenta in an early pregnancy?
Yes.
You are not supposed to see for the placenta. That doctor whosoever is doing the ultrasound is not supposed to see for the placenta, but the thickened part of the decidual reaction, that is the chorionic frontosum. What is more important, the location of the bleed or the volume of the bleed?
Location.
Location is mentioned here. Where is the location? Can I go to the PPT? Now let us go to the PPT and see about this chorionic frontosum. The important point is that if there is a 2 cc, a small 2 cc or a half cc detachment which is at the level of the chorionic frontosum, that is more dangerous
Yes.
than a double of detachment which is detaching the chorionic leaf only. You getting the point?
Yes.
Now, how to see for that? That is his job. But it is your job to ask him whether this is at the level of the chorionic frontosum or detaching the chorionic leaf only. If there is a, again repeating, if there is a 10 cc detachment at the level of the chorionic leaf, that is not as dangerous as is the 2 cc at the level of the chorionic frontosum. Now next time, whenever the patient will come, with a small bleeding, you will ask for the location. You will tell that doctor, whosoever is doing the ultrasound, you will tell that doctor what is the location, and if it is at the level of the chorionic frontosum. We are teaching in our courses how to see for this and that. Today we are discussing the reports only. We are not discussing how to see for that. But I want you to get aware of what you have to ask from your patients. Okay. So now the next doctor with me is Dr. Sunita. Dr. Sunita. Dr. Sunita, first of all, can I have the mic of Dr. Sunita? Give me the mic. Dr. Sunita. Yeah. So the next is Dr. Sunita Gagoti. She is from Mumbai. She is also having one case. Let's discuss that case with you. What is, madam, the case where you want to discuss that case? What you want to discuss with me? Early pregnancy scan. Can I see the report? Or can you verbally tell me what is the report? Was that report normal? Tell me yes or no. So, was yolk sac mentioned over there? Yes or no? No. So we will not repeat this. Yolk sac is very, very important because yolk sac will decide whether this is a normal or an abnormal pregnancy. So first point is the yolk sac, which was not mentioned over there. Now see, today we are discussing 3 cases. In no case the yolk sac was mentioned. Now next time you will ask for the yolk sac. Number 2, was there any detachment, yes or no? Okay, small detachment, we have discussed that small detachment. Was it mentioned? Where was that detachment? Was that detachment at the level of the chorionic frontosome or the leaf? Was it mentioned? So point number 2, you have to ask for the location. The volume is important, but more important is the location. You have to see for the location. Point number 2, location of detachment, if any. Point number 3, fetal cardiac activity was mentioned there, yes or no? How much was the fetal cardiac activity? The report is with you. How much? 100? So how much it is written over there? 100, 99, 105. How much is mentioned over there? 100. Okay, now see, 2 points we have discussed. Okay, I am muting the mic because now I am discussing the fetal cardiac activity. The fetal cardiac activity 110. Can I have the PPT of fetal cardiac activity? Now the fetal cardiac activity of 100 beats per minute. Per minute 100 beats. Can be normal, can be abnormal. I am using word can be normal or abnormal because I have to correlate this fetal cardiac activity with the CRL to say whether I am dealing with a fetal bradycardia or normal. Now, whenever a report is coming to you, it is not usually mentioned whether it is a normal or an abnormal because I have not to only make it right like fetal cardiac activity is this much, but I have to see whether I am dealing with a bradycardia or a normal, because if it is 100 and the crown rump length is a 5 millimeters, and if it is more than 5 millimeters, then it is for sure bradycardia. I am repeating, if it is 100 and the fetal CRL is more than 5 millimeters, then you are dealing with a fetal bradycardia. The CRL will decide whether I am dealing with a bradycardia or not. And if I am having 100 and I am having a lesser of CRL, then maybe that I am not dealing with a fetal bradycardia. And if remember this thing, if you are dealing with a fetal bradycardia, then there are very high chances that you will be losing that fetus. Now see our in PPT. Heart rate of less than 80 beats in an embryo with a CRL of 5 is having a high embryonic demise. Now you are having 100. So next is that if the heart rate is in the bracket of 80 to 90, there are 60% chances of the risk is there. 60%. 90 to 99 beats, 32% of risk is there with a CRL of less than 5 millimeters. 5 millimeters is the cut. But even if you are having even if you are having 100, still the risk is there of 11% risk is there. It means that in your patient there is a risk of 11%. If the CRL is 5 and less than 5. Now, if there is a CRL which is in the bracket of 5 to 9 millimeters, then this 100 and 105 is 110 is even abnormal. You should have a fetal heart rate of 120 and more. So the moral is that you have to see how much is the fetal cardiac activity, and you have to correlate that fetal cardiac activity with CRL. If it is not corresponding, if it is less. Now see, I am worried with bradycardia. I will not much worry with tachycardia, because this bradycardia is having a risk. If your fetal heart is having a 90 or 80 beats, about a 60% you will lose. So the moral is that whenever a report is coming to you, don't see it as you are seeing it like it is normal. Ask for these things, see for these things, and ask your doctor whether you are dealing with a normal. Then you can decide whether it is a normal or abnormal. Maybe that you are dealing with an abnormal pregnancy which is coming with a tag of a normal pregnancy. Then you are blaming yourself. Maybe that I did something wrong in treatment. Maybe that it is your fault. But what I am seeing, where is your sac? What I am seeing, where is the location? What I am seeing, it is not labeled whether it is bradycardia or not, because it is not correlated with CRL. Dr. Jyoti Malik, you have anything to add on?
Sir, I would like to only say that at times we are missing this yolk sac and the things that we have mentioned. So it's very important that we make a habit of doing these things, and we make a note that we should add it in reports only, so that we are not able to miss. And at times in yolk sac, only the thing that I would like to add is sometimes there is on putting color Doppler, although we are not using color Doppler for early pregnancy scans, but whenever we are finding any abnormality in yolk sac, in few of patients I have seen, I just put the color Doppler mode on, and there is some venous congestion there. So that is also going in favor of poor prognosis.
Okay, thank you very much. So this was all about today's discussion. So the important points what are coming out is that if you know the things, then only you will start dictating to that doctor who is doing ultrasound. If you are not knowing that this thing is required, that thing is required, you will take that normal ultrasound, which is not actually a normal, you understand, which is not actually the normal but an abnormal. But if you know your stuff, then only you can do these wonderful treatments, and you will not lose your patient, and then the patient will not start asking questions why this pregnancy is lost. So yeah, thank you very much, Dr. Sunita, Dr. Harjinder Kaur, and Dr. Jyoti Malik for joining us. We will be taking these types of panel discussions at regular intervals. Thank you very much. God bless all of you.
Thank you, sir.